Hello and welcome to this webinar, Immunization Coverage Rates in Texas. My name is Robin Carlisle and I'm the Education Program Manager for the Immunization Partnership as well as an instructor of community health workers at Dia de la Mujer Latina. During this webinar, we will be talking about what immunization coverage rates are like in Texas across the lifespan, as well as how these rates compare to national levels and the Healthy People 2020 objectives. We will also talk about where the greatest gaps exist with vaccination coverage in the state and where more outreach and education could be applied to improve rates in underperforming areas and populations. So let's get started. As you can see, national rates have improved for early childhood vaccination, albeit slowly, over the past several years, especially for children 19 to 35 months who receive all 7 of the primary vaccine series. Texas, on the other hand, has been slightly less consistent. We made huge gains from 2009 to 2011, but after that, rates have fluctuated. The reasons for these fluctuations aren't very well known. We aren't sure if they are due to changes in sentiment about vaccines or vaccine-preventable diseases, changes in access to vaccines, or potentially just the way that the rates themselves are collected through the National Immunization Survey. We're just not sure. Regardless, however, the past couple of years have really shown that we have fallen behind the national average and don't appear to be making consistent progress toward the Healthy People 2020 objective of 80%. For those who might not be aware, the Healthy People 2020 objectives are a set of standards put forth for the United States across a wide variety of health outcomes, with the hopes of achieving these measures by the year 2020. The result, of course, will be a healthier nation for all people across the lifespan. There are several Healthy People 2020 objectives that pertain to vaccination, and while we have had some remarkable success in Texas in a few key areas, we will have to make up some major strides in the next few years if we want to achieve these objectives by 2020 and protect our communities from vaccine-preventable diseases. When we break down the early childhood vaccination rates for the 7 vaccine primary series by a number of factors, we start to get a little bit more perspective on where some gaps might exist. In 2015, there didn't appear to be a major difference among the various poverty levels. Rates were fairly comparable in those children 19 to 35 months who were living at or above the poverty line versus those living below it. However, when we look at rates by race and ethnicity, we do see a little more variation. Here you can see that non-Hispanic Black children have the highest rates for the 7 vaccine combined series in young children, followed by non-Hispanic white children and non-Hispanic Asian children. Those who identified as multiple races had the lowest vaccination rates, though it's important to note that there weren't that many children included in the National Immunization Survey who identified as multiple races, so this rate might not actually be representative of all kids in this racial group. Among the 4 major races and ethnicities, Hispanic children had the lowest vaccination rates for this age group. Now let's look at where these children live. Those living inside the central cities of metropolitan areas have higher rates than those living in non-central cities or suburban areas. Now, with all these demographics in mind, we can identify some gaps where more education and outreach could be focused to improve immunization rates in young children. Because no income level jumps out, it's important that efforts continue to be focused across all income levels, with special attention paid to families with Hispanic and multiracial children who are living in non-central cities and suburban areas. Now, switching gears, let's take a look at the adolescent rates in Texas. There are 4 vaccines routinely recommended for adolescents, and the percentage of teenagers 13 to 17 who have been vaccinated against diseases like whooping cough or meningococcal disease has already surpassed the Healthy People 2020 objective, which is excellent. Meningococcal disease in particular is a disease that can lead to very serious consequences in adolescents and adults. So the fact that rates against those diseases are so high is very encouraging. Unfortunately, however, rates for vaccination against human papillomavirus or HPV, which can cause cancer, as well as flu, are significantly lower. We only vaccinated about half of Texas teens against flu in 2015, and rates are fairly similar for those who have received at least 1 dose of the multi-dose HPV vaccine series, although we do have higher rates in females than males. Why the disparity between the meningococcal and pertussis vaccines versus flu and HPV matters is because HPV and flu actually kill more people in Texas and the United States than whooping cough and meningitis do. This chart is from MD Anderson, and it shows how many deaths were believed to be caused by meningitis and whooping cough versus select HPV-related cancers. And the difference is quite astounding, especially in light of how much lower vaccination rates are for HPV compared to the other adolescent vaccines. If we were to incorporate flu into this chart, it would be even more astonishing. An average of 23,000 people die every year from flu in the US alone, so that would dwarf the figures seen here on this chart. When we zoom in to look at vaccination rates of specific locations across Texas, some interesting differences crop up. Across the state, rates for meningococcal disease and whooping cough vaccination are high, but when it comes to HPV, rates vary quite a bit. Bexar County, where San Antonio is, has the lowest HPV vaccination rates compared to Texas as a whole, and other specified locations, whereas El Paso County tends to have much higher rates than the state average. Breaking down rates for Texas teens who have had at least one dose of HPV, rates are lowest among those who live at or above the poverty line. This breaks with many other public health outcomes. Often in health, we see that low income is where we see the decline. But as you can see here, that's not the case with the HPV vaccine. Those who are below the poverty line are actually much more likely to have received at least one dose of HPV vaccine than their wealthier counterparts. And when we look at HPV vaccination rates by race and ethnicity, the group that is the least likely to get the vaccine is non-Hispanic whites. This again breaks with traditional indicators when it comes to health. Hispanic teens and non-Hispanic Black teens, on the other hand, are much more likely to start the series than their white counterparts. If we look at HPV vaccination rates broken down by geography, something interesting comes out. While teenage girls in non-central cities and suburban areas were the most likely to be vaccinated compared to girls in other environments, boys living in rural areas were more likely to receive at least the first dose of the vaccine. The difference could hint at how families think about vaccinating their boys versus their girls varies according to geographic area. And this information could potentially be useful when we are crafting education and outreach efforts for HPV vaccination in the future. When we look at the whooping cough and meningococcal vaccines, there is a slight difference when it comes to poverty lines. Like in the case of HPV vaccination, those who are at or above the poverty line are less likely to get vaccinated with these two vaccines. Race and ethnicity differences are also fairly similar to HPV, though the differences aren't quite as stark with these two vaccines. Non-Hispanic whites lag behind Hispanics and non-Hispanic Blacks in terms of vaccination coverage for whooping cough and meningococcal, but it's important to note that rates are still above the Healthy People 2020 objective for each of these three races and ethnicities. Rates are high across the board. Interestingly, the same trends found with HPV vaccination with regards to geography aren't the same as the Tdap and MCV4 vaccines, but the differences among the various environments really appear to be very minimal. Again, these vaccination rates are very high regardless of where the adolescents live. So what does this tell us about gaps? Well, it varies slightly depending on the vaccine, but trends indicate that it would be beneficial to consider outreach efforts aimed at improving adolescent vaccination rates should be focused on higher income, white families living in urban and suburban environments. That's where the lowest vaccination rates appear to be trending. Now I want to pivot slightly to rates for school-required vaccines specifically. All 50 states have minimum vaccine requirements for school entry, but 3 allow parents to opt out for non-medical reasons. In Texas, parents can choose to opt their children out of school-required vaccines because of any personal belief. That includes religious reasons as well as others. And the number of kids being opted out of vaccines for these non-medical reasons is growing here in Texas. During the last school year, nearly 45,000 students had a non-medical exemption on file, and that's a 19-fold increase from when they were first allowed in 2003. And that trajectory appears to be only climbing. Why this matters is because research shows that people who opt out of vaccines tend to cluster in the same schools and same communities, and that leaves those places vulnerable to outbreaks of diseases like measles and chickenpox if vaccination rates fall too low. Thankfully, the overall rate in Texas of students who opt out of at least one vaccine is low. Less than 1% of students opt out of vaccines for non-medical reasons. But the steady and dramatic increases we've seen over the past decade is really cause of concern. So how do these exemptions shape vaccination rates? Well, non-medical exemption rates for kindergartners are actually higher than the overall average, whereas the overall average is less than 1%. Non-medical exemption rates in kindergartners are at or above 1% for all of the vaccines listed here. And as these rates go up, we are seeing slight declines in vaccination rates for individual vaccines. But we have done a great job here in Texas of getting our vaccination rates above 95% for the state as a whole, which is great, especially when we're thinking about herd immunity and protecting our state from diseases like measles, which can be very contagious. But it's important to remember that these are state averages, so individual school rates vary quite a bit depending on where you look. Some schools, for example, have vaccination rates below 50% for some vaccines, and that's particularly worrisome for the highly contagious diseases like measles or chickenpox. Seventh graders have rates that are slightly lower for non-medical exemptions. These tend to be below the state average. And like in kindergarten vaccination, we see rates above 95% for all of the required vaccines, which is where we'd like them to stay. Now, I mentioned that those are state averages. When we look at a smaller scale, in this case, the 25 most populous counties in Texas, the ones with the highest non-medical exemption rates tend to cluster in Austin and in North Texas. So here's a map where you can see this more clearly. The darker and bolder the red, the higher the exemption rates. And as you can see here, Central Texas and North Texas are hotspots for opting out of school-required vaccines. Although we are seeing some trending upward happening in the Panhandle and in the Permian Basin area. So how can we better target outreach efforts to reduce non-medical exemptions? Well, we should focus on families with younger students, preferably before kindergarten, who are living in affluent white areas near Austin and the Dallas-Fort Worth area. Although there really is a need across the entire state, especially when we look at individual school rates and how they can vary within a given community. Okay, so now let's talk about flu. We briefly touched on flu when we discussed adolescent vaccination, but given the importance of this vaccine, let's take a deeper dive into what rates are across the lifespan here in Texas. The CDC recommends that everyone over the age of 6 months, with very, very few exceptions, get vaccinated for flu every year. And while we have made steady progress on vaccinating young people, as you can see here, we haven't made great strides with adults. And here's what I mean. Rates have gone up, in some instances drastically, with children and teenagers over the past several years. But adult rates have had less consistent gains. That being said, it's important to note that we have achieved Healthy People 2020 objectives with two extremely important groups, small children and older adults. Where we are failing, however, is with young adults. Young adults under the age of 50 may not be at risk for severe disease or death as a result of the flu, though we have lost some young adults to the flu in the past, especially to H1N1. This age group is certainly the most likely to spread the disease, however, to those who are more vulnerable. This is the age group that is likely to have young kids in the home, have pregnant partners or become pregnant themselves, and also care for aging parents and grandparents. It's important that flu vaccination rates increase in this age group to help better protect the people around them that they might infect. Broken down by race, non-Hispanic Black and Hispanic individuals are less likely to get vaccinated for the flu compared to their other racial counterparts, or the other counterparts in other races and ethnicities, though trends would appear to indicate that progress is being made with these minority groups, especially with Hispanics. Now let's take a look at another vaccine for adults, the pneumonia vaccine. Here in Texas, a little over 2/3 of adults over 65 have gotten the pneumonia vaccine. And while that's very good, that's far short of the Healthy People 2020 objective of 90%. So we're making great progress, but we still have a long way to go when it comes to the pneumonia vaccine in adults over 65. When we look at gender, women are more likely than men to have received the pneumonia vaccine, which is a common factor found in many other health areas. And non-Hispanic, Black, and white individuals are more likely to receive the pneumonia vaccine than Hispanics. Hispanics over age 65 are substantially less likely to have received the vaccine. When we look at income, it is also those who are in the lowest income bracket that are the least likely in Texas to have been vaccinated for pneumonia. And it's important to note that this could be due to the fact that there is a large percentage of the adult population in Texas that do not have access to health insurance. Looking at the zoster or shingles vaccine, this vaccine is recommended for those 60 and over, but it can be given as early as age 50. Rates overall are very low for shingles in Texas. Only about 19% of adults overall and about 53% of adults over 60 have been vaccinated. Like with the pneumonia and flu vaccines, Hispanics are the least likely to have been vaccinated against shingles, especially when compared to non-Hispanic whites of the same age group. And again, similarly to pneumonia vaccination, the lowest income level is where we see the lowest rates in older adults getting the vaccine. Now, in the US, it's recommended that all adults 19 and older receive the whooping cough shot, which includes protection from tetanus. And then a simple tetanus booster, with or without the whooping cough component, is recommended every 10 years after that. When we look at the whooping cough vaccine, however, only about 17% of adults overall in Texas have received the vaccine in the past 8 years. Though given the high percentage of people who aren't sure whether they received the whooping cough formulation or just the tetanus diphtheria version of the shot, it is possible that that number could be higher, but even still, that is a very low vaccination rate for whooping cough. Broken down by gender, similar to what we've seen in other vaccines, women are more likely than men to have received the whooping cough shot, but overall, they are less likely than men to have received any kind of tetanus booster. With Tdap now being recommended during each pregnancy and more education being shared about the importance of vaccinating young families, it's no surprise that whooping cough vaccination rates are higher among younger adults compared to older adults. Older adults were the least likely to have received any kind of tetanus shot in the past 8 years, let alone one that included the whooping cough component. This is important because young children who become infected with whooping cough typically get the bacteria from a relative, and that includes siblings and parents, but it also includes grandparents, anybody who's in the nuclear family who's going to have continuous contact with that infant could potentially pass the bacteria onto them without realizing it. And that's why vaccination in adults against whooping cough is so important. When we look at race and ethnicities for whooping cough vaccine, again, Hispanics are the least likely to have received the vaccine recently, but non-Hispanic Blacks are the least likely to have received any kind of tetanus booster regardless of type. And lastly, as we saw with other adult vaccines, income appears to play a big role. The lowest income bracket is, again, the least likely to have been vaccinated when it comes to tetanus shots and whooping cough vaccines. So what does this mean for education and outreach? Well, if we want to improve vaccination rates among adults, it might be beneficial to focus efforts in low-income communities with large Hispanic populations. When looking at shingles or flu in particular, we might want to consider prioritizing younger adults to ensure that we get those rates up. And for tetanus and whooping cough, the older adult population might need more outreach. And with that, I will conclude this webinar. Thank you very much for tuning in.